Great. All right. Thanks, Mark. And thanks, John, for a great talk. I learn a little bit when I hear some of my colleagues talk. So it's a lot of fun in that regard. For any Cubs fans out there, it's 6-4 in the bottom of the seventh. So it's going to happen. All right. 6-4. My journey into becoming a sarcoma surgeon in many ways started with this man right here. His name's Raphael Pollock, and he was the chairman of surgery down at MD Anderson when I arrived down there. Seems like a long time ago to start my fellowship. My very first day of fellowship, I walked into a room, an exam room, and a patient was there with a sarcoma of the foot. Now, where I trained in general surgery just down the road at the University of Chicago with Dr. Peabody, who's now with us here in the back, if it was an extremity sarcoma, that went to the orthopedic oncologist. If it was something in the abdomen, that went to the general surgical oncologist, and that's just the way we divided it. Dr. Paul, I excused myself. I said, you must be in the wrong room, and I walked out, and I went and found Dr. Pollock, and he says, we treat anyone that's sent to us, and it was a very, very, very powerful lesson, and it's one that's guided me in my professional career from that point forward. And I think all of the doctors that work here in this room would probably abide by the same principles, that we're here to treat anyone that's sent to us, anyone that needs our help. And if we're not the right person to treat that patient, we will find the best person to treat that patient. So we're going to talk a little bit. John's covered some of these issues already, and so we can move quickly through some of these topics, but we're going to briefly cover diagnosis of sarcoma, treatment approaches, especially the surgical treatment of sarcomas, and then I'm going to turn the podium over to my partner, Dr. Bilimoria, who's going to talk to you a little bit about some of the work that we've done and that he really specializes in outcomes. In other words, studying our results and using that data to improve patient care. So I thought I'd start this part of the talk with just a little brief case presentation, and I don't think this is any of you here in the audience, but if it is, forgive me, but it probably is a familiar story to some of you. The patient we saw was a 40-year-old gentleman. He had a 2-week history of fullness in his thigh. He was an avid, very active man, avid weightlifter. He reported some mild tenderness, and so went and saw his internist, who thought maybe he pulled a muscle. He gave him a prescription for some physical therapy and put him on some non-steroidal medications. But predictably, he didn't get better. And 2 months later, he came back to see his physician with increasing fullness despite not limiting his activity. And then was sent for an MRI. And this is what we saw, this large mass. And again, it's not uncommon to see these quite large masses in patients. You can actually hide a pretty big mass in the thigh before it really draws your attention. And the biopsy revealed sarcoma. So as John told you, these are relatively rare cancers, and I think that's part of the challenge. For the average internist out there, of every 100 masses that might walk into their office, really only one might be concerning for a cancer. And so it's somehow understandable to see how these can be misdiagnosed, especially at first. I think the main point to make in sarcoma, though, is when we are able to find these lesions when they are early, they're often curable. However, when they're recurrent or metastatic, the prognosis is much more guarded. And again, the thing that's drawn me to this disease and has given me passion to treat this disease is the principles of multidisciplinary management, meaning we have a team that helps manage these patients. And I played sports growing up, and being part of a team was always very important to me. And in the same way, we have a team here at Northwestern where everyone has a role and everyone has an important voice. And it's really when we act together as a team that we give our patients the optimal treatment. Now, sarcomas can happen anywhere throughout the body, which is also another reason why, as a surgeon, these are fascinating tumors to treat. They can be at the back of the abdomen, the extremities, the trunk, the head and neck, and we will treat them all over the body as they come to us. As John told you, they can arise from essentially any type of tissue. Fatty tumors are called liposarcomas. Skeletal muscle tissues are called rhabdomyosarcomas. Tumors of the blood vessels are called angiosarcomas, and so on. So this is one way that we attempt to differentiate these tumors, but basically sarcoma, and this is probably one of the things that stymies our progress in treating these tumors, is that really it's a catch basin for what might be very, very, very different tumors. In other words, a liposarcoma, especially a well-differentiated liposarcoma, acts very different than a highly aggressive grade 3 fibrosarcoma. Under the microscope, they look different, but they all essentially have some characteristics of the cell they come from, but as they get more aggressive, will look much essentially unlike any tissue that we would normally have in our body. So like our patient that we just talked about, these often present as painless masses. They're often quite large, and diagnosis, as John told you, is often made by MRI or CT scan, and then preferably a needle biopsy. This was a patient I treated early on in my career here, presented with an enlarging calf mass, and then was ultimately found to have a leiomyosarcoma of the calf. This is another gentleman we treated here a few years back who basically walked into his doctor's office with what he thought was an enlarging beer belly, but clearly had a large fatty tumor within his abdomen. So I think the issue with sarcoma is you probably have one chance to get it right. And we've all seen those cases that come to us where we wish we kind of had a do-over. This is a gentleman who had an open biopsy, you can see here, which was oriented transversely across his leg. Now, unfortunately, to re-excise this is going to require an extensive plastic surgery procedure to reconstruct that, whereas if the surgeon who did this oriented the scar up and down the leg, we perhaps could get that right back together after we did his surgery. This is another gentleman who had a biopsy, and as you can see here, unfortunately, there was some bleeding in the area around the tumor afterwards, and you can imagine all this blood that tracked down the compartments of his leg clearly could have carried with it tumor cells, and this again presents a very challenging situation to us when that patient finally arrives at our door. So, it's somewhat self-serving, you might say, that as a panel, as an NCCN panel, that we say that we start our guideline is, the very first thing, if you turn to the very first page of the guideline, that all patients should be managed by a multidisciplinary team with expertise in sarcoma. And we've written the same thing. I've been on the panel since 2001. And every year we rewrite the guideline, and every year this is the sentence that starts it, because I think all of us who treat sarcoma and all of us who sit on this panel, really in our hearts believe that it's only through teamwork and getting the expertise of all the different doctors that treat sarcomas that we can really have the best outcomes. So as John told you, once the diagnosis has been secured by a biopsy, we get some additional imaging just to make sure the tumor hasn't spread. And typically that's some type of imaging of the lungs. If the lesion is small and it's a low grade, meaning less aggressive looking tumor, a chest x-ray might suffice. If it's a larger or high grade, more aggressive tumor, then we certainly would probably go to a CT scan of the chest. And then we plan therapy. This was a study that came out of Memorial Sloan Kettering that just shows you why we concentrate so much at the chest. If these were their cases of sarcoma and looked at sites of metastasis, you can see in the extremities, almost all of them go to the lung. In other words, travel hematogeneously, unlike other cancers like melanoma, like breast cancer, like colon cancer, which preferentially typically spread to lymph nodes. Now, we need to stage the patient, meaning we need to put them into groups, and being in what group you're in might determine how we treat you. Typically, if you have a smaller, more superficial tumor, which is low grade, you're going to be stage 1. If you have an intermediate or high grade tumor, even if it's small, you're going to be grade 2. And if you have a high, large, aggressive looking tumor, that makes you grade 3. Any spread to lymph nodes or beyond is considered stage 4. And in surgery, we typically will focus on these patients above the red line. If a patient presents with metastasis, especially if it's not just a simple isolated metastasis to the lung or the liver. That typically, again, as John told you, that's typically a case where we can't, as local therapists, physicians who only treat one part of the body, that's not a place where we can have a significant impact, and we need to call on our colleagues in medical oncology to consider some systemic therapies. Now, I'm here to talk to you a little bit about how we approach these lesions surgically. Now, even in 2015, surgery still remains the mainstay of treatment for all patients with soft tissue sarcomas of the extremities. However, we need to be able to, and we need to ensure that we'll get what we call a negative margin, meaning get all the tumor out. Now, that's where colleagues like Dr. Hayes and radiation oncology can help us by radiating the area and theoretically allowing us to take smaller margins, because it's not uncommon that these tumors will be up to very critical, opposed to very critical structures like bones or blood vessels or nerves. And if you take those bones or blood vessels or nerves, I mean, we can do all that, right? But if we leave someone with a limb, an arm, or a leg that doesn't really function well, then we've kind of cut off our nose to spite our face. So we want to avoid that situation when we plan a surgery. And again, we try to get these tumors out with no tumor left behind. And if we can do that and do it, right off the bat, and all the margins are clear, and it's a low-grade tumor, we might not need radiation. But in vast majority of cases, we do add radiation to our treatments to ensure that these lesions will not recur. Now, this is again, the operation you want to avoid. As John told you, sometimes we call this the oops operation, where someone just goes in and thinks they've got a benign mass, and they simply take out the mass. Well, we know sarcomas don't have true capsules, meaning they don't have a tough fibrous coating around them that holds all the tumor cells in. What they have is what's called a pseudocapsule, or a compressed layer of tumor cells around them typically. So we need to ensure that we take out some normal tissue in all directions if we're truly going to get a negative margin. Now, early on, this led people to do real ultra radical resections. In other words, taking, for instance, like all the an entire muscle or entire group of muscles in a particular component. Again, this is somewhat more disfiguring, somewhat more leads somewhat more to functional impairments. And so over time, and with the use of adjuvant therapies like radiation, we've been able to get away from something like this, which is an amputation. And in this day and age, we only probably treat about 5% of our patients require amputation. And we're able to do something that looks more like this. In other words, taking the tumor with a centimeter or two of normal tissue in all directions. And this is a specimen of one of our patients who underwent radiation and underwent radical resection of not only the biopsy site, but the entire tumor with a kind of a small rim of muscle and fat in all directions. In other words, my goal is to never see that tumor when I'm in the operating room. I only want to see normal tissue in all directions around it. And this was the kind of landmark study that showed us, why we don't need to do radical surgeries or amputations in sarcoma. This was a study done by Steve Rosenberg, who's the chair of surgery at the NIH. And what he did was he randomized patients to amputation plus chemotherapy versus what we call limb-sparing surgery, which is what we aim for in this day and age, plus radiation plus chemotherapy. And what he was able to show is there was no difference, statistically no difference in recurrence-free survival and overall survival. And so this has kind of been our guiding principle in this day and age of surgery for sarcoma. So if I just had to kind of give you a capsule, and I remember I told you we needed to stage the patients to show what the treatment options are. If someone has a low-grade small tumor, surgical resection in and of itself may be possible, and I saw a woman today post-op who that was the case, but it's probably rare in this day and age. If someone has a slightly larger tumor and it's still low-grade, because of the size, because of our wanting to preserve limb function, we will typically use resection plus or minus radiation. If we have a larger high-grade tumor, these tumors we almost always treat with radiation, either typically before surgical resection. And these may be the patients that we consider actually giving chemotherapy to either ahead of surgery or after surgery, because frankly, we've gotten pretty good at preserving limbs, and we've got pretty good at decreasing our risk of local recurrence, in other words, the tumor coming back in the area where we've operated, to relatively small percentages of these patients. But what's going to unfortunately ultimately get a lot of our patients is the tumor cells which are present from the get-go, spreading through the bloodstream and then embedding in the lungs, and then eventually growing into tumors that we can see on our CAT scans, on our follow-up chest imaging. And so trying to get chemotherapy early into our patients we hope ultimately impact survival. And Dr. Agolnik's going to talk, I'm sure, much more on this later on. These are our Nccn guidelines, and again, just to show you in kind of an algorithmic form, and these are available online. You can actually print these up on Amazon. If we have stage 2 or 3 resectable disease and we can resect the tumor with acceptable functional outcome, we will typically go to surgery, radiation after surgery, and then just follow up, radiation first, then surgery, or chemotherapy, then surgery, and then radiation, or some combination of those therapies. And it's in our Multidisciplinary Sarcoma Conference, and we meet every other week to discuss all of our patients who have complex tumors, that we decide which is the best arrow to follow for each individual patient. And it's that kind of individual attention to all of our patients that I think makes our approach not necessarily unique, because I think other places do things similarly, but it's certainly the amount of time and effort we put into coming up with these decisions, no doubt in my mind, leads to the very favorable results that we're able to achieve. Now, again, as I mentioned, if you have concern for adverse functional outcomes or there's possibility of spread, that's when we might start with chemotherapy or radiation first, so that we can potentially do a smaller operation down the line. So I think the only other last thing I wanted to touch on before I turn the podium over to Karl is that follow-up is also important. So not only after surgery does our role in the treatment of these patients end. I think most of you who are my patients, certainly will follow up with me and with your other physicians regularly, and we'll look at not only functional rehabilitation, but also periodic imaging to rule out recurrences down the line. So my final conclusions are that sarcomas are a rare, heterogeneous group of diseases. They certainly pose challenges that need to be overcome. Progress is being made, however, and I think you can all hopefully take that from all the talks that we give you tonight, and that new approaches are needed, and we're working on that. And so with that, I'm going to turn the podium over to my partner, Dr. Bilimoria, who's going to give you a little flavor of some of the...
All right, well, welcome. It's fun to see some familiar faces here, and like to go through a little bit of what we do, and we're pretty proud of some of the work that we do in this area. We're recognized nationally for really driving how we deliver high quality care. We have a lot of ideas about what the right thing to do is, but does it always happen? And how do we get people to do the right thing here in the state and across the country for sarcoma patients? And so here is a graph that tells us about quality in different industries and productivity or efficiency. So airlines, telecommunications, the banking, all in the good sector. They're low quality or high quality, low error rate, and very productive and efficient. Health services is a huge industry, and it's sort of in the wrong sector, and we're trying to work on that and really improve that. But we're not alone. All right, so this is another study that's really a landmark, and it just sets the stage for what I want to talk about. This study looked at a number of different medical conditions. It included cancers, acute problems, chronic problems, and what they wanted to look at was how often did people receive the care that they're supposed to receive for the entire sort of spectrum of what they needed. There were known things that should be done in diagnosis, in treatment, in follow-up, and how often did they get all of those things? And it turned out across the country, small hospitals and big, it was only about 55% of the time. It's pretty profound. And so I've spent the last 10 years trying to impact that number for a variety of cancers, and sarcoma, being one of my favorites, obviously, is one where we spend a lot of time on that. We know that there's also a lot of variation in outcomes, and depending on how good the care is at that facility, it does translate into differences in outcomes. So we looked at this in a number of different cancers, but in the short term and in the long term, if we could bring the care at the low-performing hospitals up to the high-performing hospitals, just for these cancers, these are a small subset of cancers, we could save 10,000 lives a year. So that's why there's real value in trying to understand how we get everybody to sort of get the recommended care. So how do we do that? There are a number of things that we can do. One of the first things is accreditations, and there are groups like the National Cancer Institute or the Commission on Cancer. It's funny that we talk about the Commission on Cancer because they've been here doing a site visit and assessing our cancer care for the last couple days. So they do on-site visits. We provide them with detailed data about our performance, and we are designated by the NCI Cancer Center. We have been for 20 plus years. And by the Commission on Cancer as well. And these groups set standards for clinical care, multidisciplinary conferences, what Dr. Wayne was talking about, where we all get together and really take care of these complex cancers together. They also require us to examine our results and find opportunities to improve care and really focus on research and clinical trials. The other group that we're part of, and the other way that we can improve care, is to have guidelines on how to treat cancers. And Dr. Wayne showed you some of the algorithm from the National Comprehensive Cancer Network. We're one of the founding members. These are 26 cancer centers that set the standards and the guidelines for how we should treat cancer care. And you can go to this. This is on the website, or on their website, and you can really step through in a stepwise fashion. It's really meant for you to go through probably with your physicians, but there's also a patient-facing version as well. But again, another way to improve quality is to get the patients involved and have them be advocates and understand this as well. And so frequently, Dr. Wayne and I certainly go through this in the clinic with our patients and really to sort of step through this. Again, just looking for ways to make sure we're getting the right treatment all the time, or the right sort of approach all the time. So, my picture disappeared, but it was a really nice picture of all of us sitting around a table talking about sarcoma cases. So, okay. But we have multidisciplinary tumor conferences here for a number of cancers, but I will say that the one for sarcoma is particularly good. So we get everybody together. All the people you see here, so medical oncology, radiation oncology, surgical oncology, orthopedics, the pathologists, so we can look at the slides together, and we get the radiologists together so we can all look at the images together and think through the problem together and come up with a comprehensive treatment plan. The pathology is particularly important. Studies have shown that when we review the pathology that's been read at another place that maybe doesn't specialize in sarcoma, the read changes 30% of the time. And 15% of the time, it actually changes the management. That's across a variety of cancers, but it's undoubtedly true for sarcoma, where the pathology is fairly complicated. Similarly for imaging, reviewing the imaging here, we frequently find things that other places maybe don't. We have people who are particularly interested in looking at sarcoma and images for sarcoma, and we benefit from that. The other option is that there are a lot of clinical trials, and if we were just sort of sitting there by ourselves taking care of patients, we wouldn't think of everything and think of clinical trials that are open maybe at our institution. But when we're all together, we can really make sure that that happens, and Dr. Agolnik's really good about reminding us about those things. So, so this gentleman was at the Massachusetts General Hospital. This was in the early 1900s, right around 1900. His name is Ernest Avery Codman, and he was actually a sarcoma surgeon. He's particularly famous because he was the first one to really think about keeping careful records of what you did for the patient and how the outcomes turned out. At the time, he was vilified. They didn't let him into any surgical societies. They thought what he did was sort of crazy. Here he is with his case files. Each one is a chart on a patient, and where he could go back and track the outcomes every time something happened, or he saw the patient back. And not until actually last year was he really recognized, and the American College of Surgeons actually gave him a gravestone as being the father of sort of modern quality, because he was in a sort of an unmarked grave until just then. So now the Commission on Cancer, as I mentioned, accredits hospitals. But they also do for something very interesting. On all of the cases that we see here, and any hospital that's accredited by the Commission on Cancer, all the information about that cancer is sort of sent to the Commission on Cancer in a de-identified fashion. But what they do is they analyze the data and they send it back to us, and they tell us how we're doing. And so this is essentially a dashboard showing how well we're doing. This is just mock data. but on how well we're doing on different measures of quality. So how often did you give the right chemotherapy? How often did you do the right surgery? And so real time, you can assess whether you're hitting 100% or something lower, and you know that if it's lower, that's an area that you should work on. You can compare each circle here. This is sort of each one is a little circle, but each circle is a hospital. And this is a particular measure, but you can see how your hospital does compared to hospitals that are accredited by the Commission on Cancer. You can see how they do according to the state, the area, your type of hospital, which is an academic program. So you can really get a sense of how you're doing compared to everybody else. And again, it's for identifying opportunities for improvement. You can also then take it and look at each individual patient. So if a particular patient didn't get the kind of treatment that you thought, you can look into it and have a discussion with the team that took care of that patient and talk about why maybe that happened and try to improve for the future. But it's not just about the future, it's about the real time as well. So this is a system where it actually alerts us if something hasn't happened. Now this is a real way to make quality better and make sure that the right things happen. So, for example, if you were supposed to get chemotherapy within a year of your cancer, or within 6 months, or whatever the time frame is, and that point is coming up and it hasn't happened yet, it actually sends an alert to the cancer team at the hospital so they know that something has gone wrong and that they can act on it before it's too late. Pretty ingenious, I think. So this is something that we do here, and it's a powerful system. We firmly believe that everybody has opportunities to improve, and so we study our data very carefully on all of this. And we also, what we did was we put together a consortium of NCI-designated cancer centers, all of those sort of big-name cancer places, and got them together, and we compared our outcomes. And this is for sarcoma surgery complications. And these are all the hospitals in the country. Again, each circle is a hospital that takes care of sarcoma. And what we found is that each one of these is one of the NCI designated cancer centers. You can see that they're fairly equally distributed. So everybody has opportunities for improvement. We're not at this end though. The other thing we can do is develop quality measures. We can develop those standards. And again, we do that in a variety of ways, and we're particularly known for doing that. We've convened international panels for a number of different things. Again, this is the cancer center that consortium that we have. And then the other group that we started here in Illinois, so we could do this locally, is we got 55 hospitals together to work on surgical care and cancer care as well. And so these are 55 hospitals that have gotten together and share their data openly, have conversations about how to improve the quality of care together, and we run that out of our shop here. We can, again, provide very detailed information to hospitals. This is, again, just mock data, but if you find yourself here, you should be working on this particular issue. And so, in any case, we're working on a number of things. The other thing we're working on is assessing surgeon skill. That's one thing that has been relatively black box. Once you get trained, you go out into the world, and how do we make sure that surgeons keep improving and keep doing things at the highest level? And that's something that we're really working on here. But here, this was a landmark study that really showed that complications were correlated with surgeon skill. So as the surgeon skill improved, the complication rate went down. And so there is an approach to sort of studying that and then actually getting coaching. And so we're going to lead a coaching project here for our state where we are helping to ensure that we'll be coaching each other and make sure we all keep getting better, but we'll also be working with other people across the state on this. So we have a research group here called NICER-ONC, the Northwestern Institute for Comparative Effectiveness Research. We do a ton of research. All the stuff that I just showed you was run out of the NICER-ONC shop. We have a number of grants, but the American Cancer Society supports us quite a bit. This is a sarcoma study that we sarcoma team that you see here was part of the authorship. We looked at 22,000 extremity sarcomas, and we looked at, again, how often they were getting the care that was recommended. We looked at it by histologic subtype and the kind of this is for radiation, but the bottom line, what we found was what you would expect, is that recommended care was delivered at experienced centers, and the way that we can help them is by forming those collaboratives where experienced centers work with other centers, where we feed the data back to the hospitals that maybe aren't doing what we think they should be doing, and really all working together to try to understand that. This also came up in our sarcoma conference today. How often does sarcoma go to the lymph nodes? This is probably the largest study that's been done on this topic. We looked at how often sarcoma spreads to the lymph nodes. It's pretty rare, but it does happen for certain ones, and we have to be wary of that when it does. So we check the lymph nodes in certain types of sarcoma. So again, we're doing research here that helps improve quality, inform guidelines, develop guidelines, and then work collaboratively to try to make sure people are getting the right treatment throughout the country. Thank you.